will you have an increase in testicular size? In premature adrenarche, will you have an increase in testicular size? Why? Where is premature adrenarche starting from? Is it from the brain or is it from the adrenals? It is from the adrenal glands. So if it is not starting from the brain, will there be an increase in testicular size? No. Correct. So premature adrenarche does not have an increase in testicular size. Does premature adrenarche have breast buds? No. Again, it starts from the adrenal glands, not from the brain, so not true puberty, so you do not have true breast buds. Okay, if you had a 12-year-old female who started SMR changes 2 years ago, she's progressing normally, but she has not started menses yet. So you need to do a primary amenorrhea workup. Does she have primary sex characteristics? Yes. Is she outside that window of up to 14 or 16 where you have nothing? Nope. You do not need to do a workup. In a pre-pubertal boy, you have testicular enlargement at the age of 6. What is this diagnosis until proven otherwise? Brain tumor. What is your first line treatment for dysmenorrhea? NSAIDs. What are you trying to block? Prostaglandins. Good. Can children with untreated seizures be in sports? How long do you have to be seizure-free? 6 months. 6 months. What is your largest predictor of a future suicide attempt? Stents. And then just to follow up on a question from yesterday, I went down the rabbit hole about asymmetric breasts. So asymmetric breasts, in a meta-analysis over 17 years, there was only 11 pathologic asymmetric breast changes. Most of those were kids with chest wall masses. A rhabdomyosarcoma was the most often. There was also a genetic abnormality called a Poland anomaly. There was some cysts, some hematomas, and a galactosele as well. But the rest of these were normal fibroadenomas. So other things that you could have, there was one patient that had scoliosis that had been found with a body brace, and so there was asymmetric breast as well. So a good question, maybe go down and do a clinical inquiry like what you guys are doing, and that's probably more than you ever wanted to know about asymmetric breasts. So today is perhaps my least favorite topic. I think probably all of your least favorite topics in the room during your entirety at IPAP. There are certain times as providers that you will be tasked to do very unfortunate pieces of this job. So telling families that someone has passed away, giving certain diagnoses, and dealing with intimate partner abuse and child abuse are some of the things that top that list. So today is a caveat. If you are have experience with this or are troubled with this, feel free to step out. There will be a lot of pictures, so I know if you're looking at this slide deck and you're like, oh my god, there's 1 million slides. A lot of these are pictures, just to kind of get in that pattern recognition. So we'll go through this today, and then hopefully be done with it, and we'll have that. It is on your pants, which is why we were talking about this, and it does come up in real life. So when we are talking about abuse, it is not something that we don't see. So it roughly, epidemiologically, has the same statistical numbers as kids with congenital heart disease, as kids with some sort of congenital anomaly. So the same amount of children that you see with those type of things, you will likely see in abuse situations as well. What does that actually mean? Well, that means that every year you've got about 3 million reports that are put into a CPS, Child Protective Services, and of that, about 1 million of those every year are substantiated. So if you're asking, what are the other 2 million of those? Oftentimes those are either neglect cases that are very hard to prove, they are unsubstantiated, the if something was misconstrued, so there's a lot going on with that. But what we really want to prevent as providers, if we can, are the roughly 1,500 deaths a year. So if you extrapolated that out, that's about 30 in every state every year. So not an insignificant reason that children die. Most of these are going to be mothers who are involved with this, again, because the most common type is neglect. However, the most lethal type is going to be physical abuse, and typically that's either a father figure or a maternal boyfriend who is involved with this, usually with some sort of blunt force trauma. So if you ever see a question on your pants that says mother's boyfriend, fill in the blank, it is probably asking about some type of physical abuse to a child. As with anything, if you put inputs into a situation, those outputs can be very different. So different risk factors to be aware of. So from the parent perspective, it makes sense that if there's a parent that has any type of substance abuse problem, that's going to matter. If there is domestic violence or intimate partner violence anywhere in the household, that's going to increase the chance that somebody else is going to be, and a child is going to be abused as well. If anybody has a mental health disorder in the family, that can increase your chances. And from a child perspective, children with special needs, we talked about that could be 1 in 4 to 1 in 5 children. So any children with special needs who take more patience, more attention, more care are going to be at higher risk for being abused. Adopted children, premature children, stepchildren, all of those categories, it's thought to do with the bonding of children. So are they missing those critical time periods where they're not bonded to the caregiver? And then the rest of them should make sense. If you don't have the social support and your increase in stress or periods of transition, those should all make sense. So think about the military, we add on top of that PCS's deployments away from families, TDYs, job changes, the stresses that the military brings. So you do see slightly higher numbers sometimes, depending on where you are and what the mission set is and what's going on in military families. So we'll talk about the different types and we'll kind of go one by one as we go throughout the day. So the most common type, the one to know is for most common, if you're looking at epidemiology, is going to be neglect. So this could be neglect of any necessary component. However, this is also the one, even though it's the most common, it's the hardest to pin down often, and the hardest to prove. And so this can look like anything. We'll talk about this a little bit later. Your physical abuse is considered, if you will hear an NAT workup or a non-accidental trauma, that is how it is called in ER settings or how it is documented in notes. So NAT is what will come up. Again, typically your perpetrator is going to be a primary caregiver. So something to think about. Emotional is its own category. Again, this one is also pretty hard to pin down, especially if you have limited amount of time with these patients. Verbal abuse is going to be most often, and you can see this also in children who themselves are not having any physical abuse, but who are witnessing another parent or another caregiver in an intimate partner violence type situation. And then finally, we won't spend a whole lot of time about it, but the category of sexual abuse certainly is a large one. And that is defined as anything where the child cannot consent, is age appropriate, that would not be understood, and is absolutely in any inappropriate setting. The last one that we want to talk about, and I'm going to tell you guys a story at the end of this. If you guys have all seen the documentary on Gypsy Rose, and you've heard about Munchausen's by proxy, its new name is fictitious disorder imposed on by another. So it's the same verbiage, just updated. So it's when there is some sort of secondary gain by the caregiver if they can have the child be sickly. So red flags, this one's one to star. So this is where you want to know to be able to pick out what am I seeing from red flag perspective. So if you have significant injuries, the family comes in and they say, hey, we have these significant, there's a broken humerus, and they are unable to give you any type of story. We have no idea what happened. Just woke up like this, was often the case. So if you have some sort of complete denial of trauma and a very traumatic appearing injury on presentation, you will soon learn when you're in the hospital, if you have not already had this background. The story often changes. So you will go in and the triage nurse or a technician will get one history, and you will go in and they were like, they just told me they weren't in any pain. They tell the attending something different, they tell the med student. And so a little variation in every history is normal. What you're looking for a changing story is, we were at home all weekend. No, we were at soccer practice. No, we were up in Austin. No, this injury happened. They give you wildly different and changing stories to kind of massage what happened there. A history of inconsistent with the injury. So if they tell you, yes, I just stepped off the curb and I have a fractured femur. I don't know how that happened. And that doesn't make any sense. Repeated injuries. Like kind of the classic, just really clumsy, falls down the stairs a lot type of history that they give you. Not matching developmental abilities, and this is why doing the well child lecture was so important first, because you need to know what would developmentally be appropriate. So if they tell you something not developmentally appropriate, you can catch that. For instance, they come in and say their 1-month-old just rolled off the bed. You should at this point be able to think, that 1-month-old should not be able to roll, much less propel themselves off of the bed. They said, my 3-month-old just sat up and grabbed for it. You should think, they sit at 6 months, so what is happening? The 3-month-old is doing that. So something does not developmentally match. Looking for what's going on in the family. Is there a recent divorce, a death, a deployment? What's going on? And then an unreasonable or unexplained delay in care. Right? So this is a little bit of your provider brain that I need you to put on here. Right? So if they said, man, there was this injury happened at home and just due to the weather, we couldn't get to the ER. And you're like, we live in San Antonio. There is no weather. Very different scenario than we were snowed in with a blizzard, we're up in North Dakota, we couldn't get in for 2 to 3 days. So if this unexplained delay, it shouldn't make sense, should raise your red flag as well. And then inappropriate affect of the caregiver. So this can go either way. And I've seen this happen both directions. So in one inappropriate affect, they are totally not there, don't care. Their child is in massive amounts of distress, injured or sick, and they are playing on their phone playing Candy Crush, not a care in the world. Or they are way too involved, they won't even back up, they won't let you around the child. So you can have just inappropriate either direction. Something makes your red flag and makes your spidey sense as a provider go up, listen to that. And why do we care? So much, yes, nobody wants a child to be abused. However, hurt people grow up to often hurt people. So the complications of children that have been abused as children, they are much more likely to be abusers themselves. So much more likely to be involved in some sort of not just crime, but a violent crime. More likely to be an abuser of an intimate partner or a child themselves. More likely to have depression, anxiety, or other mental health issues, trouble with sleep. So really nothing on that list is something that you would want for a friend or family or your own child. So if we can prevent that, that is the goal of this. So knowing those complications. So how are you actually going to take a history? So this is not your standard OPQRST, right? So there's going to be some times where there are some differences to be aware of. So things to consider. Is this a cultural practice? Especially if we have foreign services that are here, sometimes they have their families. For instance, an example would be if they are from a culture where typically the man speaks on behalf of his family. That might be an instance where you would have some cultural things to consider, and that is normal cultural practices. Other things that you could think of, cupping or coining, if that is being done on back, shoulders, arms, things like that, that could be a totally normal cultural practice. It is not evidence of abuse. Second thing would be to never blame a victim, especially a child. This is certainly not their fault. The other thing you don't want to do is blame or confront the parents. So much like yesterday with the adolescents, you are not their parent, you are not their buddy-buddy friend. In this instance, you are not the investigator. not have to be the investigator or the cop. You are gathering objective data, gathering a history, and moving on from there to let the investigators do their piece. Remember, one of this, a third of the time, this is not even the primary caregiver. So if you go in guns blazing, go and blame a parent, you could end up in 1/3 of the times where it really is not them. So never blame. Do your best to keep emotions at bay, so frustration, tears, any of those things. It can get escalated, it can be very hard to do that, but as little emotion involved at the time as possible is going to be very helpful to you. What is the level of cognition that is in that scenario? So from the age and stage of the child, are they a special needs child? Are they developmentally on track with your surveillance that you're doing? Is the parent appropriate? Are they answering appropriately? So what is that level that they have with you? And then adding people to the room. This would be one that's not the typical chaperone for any kind of private exam, but this would be one that I would always encourage you to bring a second person in to have something witnessed, to have it be documented who is in there with you. This is one where we always say, don't ask, we tell you, ask open-ended questions, and then you get into some clinical and we're like, actually ask really focused questions so that the patients don't go on and on and on and on. This would be one where I would say, actually ask open-ended questions and let the child talk. They will, especially if the child is of an age where they can speak, let the child answer. If you are suspicious of this, again, you are not the investigator, but getting a good history is important, so trying to at least have an opportunity to talk to the child alone, away from the caregiver, but with another secondary witness at all times. Something to think about, if you get a incredibly exaggerated or angry response from that, that could be another one of those red flags where they don't want to be separated because they're afraid of what the child might say. Observing the patient and the parent interaction. So this is a big one. Most children, especially if you've been around children, in the presence of a stranger, will go to their parent for comfort and for care. If you are in a situation where the child who does not know you is much more comfortable going to you than the parent, that should be a red flag. So watching that interaction and making sure, do they go to the parent for care or are they very, very wary of this parent? Again, does it match? Does the story make sense? And then with the developmental age, so kind of hitting the same things over and over. So when you're getting an interview and you're talking to the child, what does that actually look like? So some of these questions just to think about when you're interviewing, and some of the ones that particularly, so we always hear, do you feel safe at home? So for a child, some of the better questions is, what do you do if something's bothering you? Who do you go talk to? What do you go say? Who can you talk to? And then a really pointed question is, do people fight at home? What do they fight about and how do they fight? So those are some of the starred ones because that will give you a lot of information about what's going on, and sometimes it's easier for them to explain what's happening with everybody else rather than themselves. So a way to start that conversation. If you are specifically with an adolescent, so it's much like a HEDS exam, you'll often get some of that same information from a HEDS exam. And again, you're starting with the friends. Do your friends get in fights? Have you ever seen a fight? Have you ever been in a fight? When was your last physical fight? Have you ever been injured? And then slowly working your way to, is anyone hurting you? Is anyone forcing you to do things that you don't want to do? Have you ever been threatened? If they're answering yes, obviously your questions are continuing. And then for the parents, and I'll tell you two stories at the end. So this one particularly, to ever ask again, you could say, do you feel safe at home? Much more pointed question. Have you ever been frightened by your partner? And then does your partner ever threaten to hurt you, or have they ever hurt you? So again, much more pointed at what you are actually trying to ask. Okay, so we will go down into these specific types of abuse. So that's really just an overview, things to think about if you are interviewing here. So, for neglect, most common type of abuse in general. Again, hardest to document, hardest to prove, most common with mom. So if you're just looking at the data. If you think about Maslow's hierarchy of needs, any of these needs that are not met can fall into that neglect. So this might be nutrition. They are not feeding the child, intentional or unintentional. We talked about in block 1, I think, or lecture 1, the family that had breakfast, lunch, and dinner. Well, that wasn't intentional neglect. It was definitely unintentional neglect. Versus the family that's just not feeding your child. So what do you think, what would be your growth chart that you might see? What would that look like? Flatline, what is that called then? When you have growth and then it just flatlines?
Failure to thrive.
Failure to thrive. And what type do you think when it's just weight involved? What's that kind of called? Wasting type of failure to thrive. Yeah, so that will often be what you'll see is a wasting type of failure to thrive here. It could mean that they're not providing any kind of home for the child. One that I have seen is educational neglect. So I was pulled into a case at a base where the family had missed 57 days of school in one semester. I didn't even know there was that many days in a semester. And when we talked to the parents, they just forgot to take them to school. So it can happen, you'd be surprised. Emotional needs, not attending to the child appropriately. You see this oftentimes with postpartum depression, when mom is having a really hard time bonding with the child. So obviously wanting to get her treatment. And then the last one is, and to be aware of, is there could be medical or dental neglect. And so this is where you really will have to use your provider brain, because oftentimes you really do need to give these families the benefit of the doubt. We couldn't make the last appointment, something came up, we had to reschedule it, the car broke down that day, man, we had to reschedule, you've missed several appointments. Yes, you're giving them the benefit of the doubt. If you're missing the newborn follow-up, 2 week, 2 month, you're not answering your phone, man can't get a hold of you, that's when you start to worry, do we have medical neglect going on? Yes, ma'am.
For that educational piece, like you homeschooling in the class, how do you navigate that?
So we were just asked to come in to say, so the question was about homeschooling and where do you draw that line? So we were asked, because the parents have been asked, do you do anything, right? So most of the time, if you have a homeschooling family, they've let the district know, here's our curriculum, here's what we're doing. These children were just running around base at all hours, like through traffic, because they weren't going to school, they weren't doing anything. So they were just asked to say, is this a normal amount of school to miss? I think any of you in this room could have said, no, that's not normal. So that's when you're putting your provider brain on, like, what makes sense, what doesn't make sense. Going to be very variable depending on what is being neglected from this child. And again, you guys nailed it on the head. If you're looking at the classic definition of neglect, not meeting those Maslow's hierarchy of needs, food, shelter, water, you're going to see this as failure to thrive and how that's going to present. And you had nailed it on the head, type 1, so the waste. Your history is going to give you most of this. What is the child going to look like? So depending on the age, so certainly if you come in failure to thrive and you're just laying there like a sad little cockroach, they can't really move, that can be one thing. You can also see kids that look like little Aladdin, right, where they're begging and borrowing and stealing food. You can do that. The other thing that you will often see is that you will see the older sibling start parenting little ones. So if you have a 5 or 6 year old, they are suddenly acting like they're parenting the 2, 3, or 4 year olds. It's called parentification, where they are assuming adult responsibilities way too early. And then if you're just seeing it in clinic, so sometimes they'll just tell you, mom's never home, I cook dinner, I give the baby the bath, I do, and you're like, what is going on right now? So sometimes they'll just tell you that. So this is an example, this was a baby, would be an example where you have multiple things going on. So in this, if you're just looking at a physical exam, does this child look like it's on the slender side, look like they're overweight? What does this child look like? Very skinny, yeah. What about the skin? Is there breakdown? You're seeing that, is it any kind of, in a region, where is that normally covering?
Right.
as in the diaper region, right? So this was a child where you're way too skinny, you have excessive breakdown in skin in a diaper region, and this child was not developmentally appropriate. So this was a case where the family didn't have any child care, so they were leaving some bottles in the crib, going off to work for the day in one diaper, and then coming home at the end of the day. So they came in for an irritant diaper dermatitis that unraveled, oh, this child actually doesn't have just skin breakdown, there's failure to thrive, there's neglect, there's medical neglect, there's caregiver neglect. So sometimes once you start pulling one string, it kind of unravels. This would be an example of neglect. When we get into these, just a warning that there are a lot of pictures here, so again, if you have some trouble, that is okay. So physical abuse is going to be the most lethal thing that you have going on. So this is typically what is responsible for about those 1,500 deaths a year. So yes, there's that significant mortality, but there's also significant morbidity associated with this physical abuse as well. So this is often the one where your history and your exam will not match. They will come in and think often that they are smarter than you as a provider, and will have a mechanism for how this child was injured that does not match what you know after you have been trained for a couple of years. And you're thinking, that does not make sense. When that happens, listen to your training. When we talked about surveillance back in the well child exam, they come in for a cough or a cold, and all of a sudden you're saying, I'm going to listen to the heart and lungs of this child. You take off the shirt, and that's the child that's in front of you with multiple stages of bruising. That would be an example of surveillance, where you're like, not that I don't care about your cold anymore, but that is now secondary to what's going on, and we are going to address the abuse that's going on first. So bruising. Bruising is probably going to be one of the most common things. Various stages of bruising. So we'll talk about, can you actually use stage of bruising for timing a bit? I need you to star right there with unusual places. So that is something to be able to pick out in life and on any kind of test. Typically, places that are protected, you should not see bruising. So abdomens are protected. You shouldn't see bruising there. Buttocks, eyes, ears, torso. Those are all examples of places that it's pretty hard to bruise. Think of all the times that you have done things in your life. Have you ever bruised your ear significantly? Most of the time that's going to be from a twisting or a pulling action. You get a torso bruise, most of the time that's from a kick, a punch, something, a pinch, something else. Yes, ma'am? Sorry, I can't hear you. Yeah, so there's pretty standard child abuse workups too, and so we'll talk about what some of that workup would be to be like, are you the one in a million that does have a clotting disorder or some sort of genetic disorder like hemophilia? That would be outside of what this pattern would typically be. So good question. What you do see is bruising that is on bony prominences. Again, if you've ever been around a child and you look up and down their arms right here, or up and down their shins, it's just like one bruise central. Right? So toddler shins and toddler elbows are a real thing. So any kind of bony prominences, to include their forehead. Their forehead is made of very, very thick periosteum, and it is made for the biggest goose eggs so that the children look like little unicorns. Frontal bone is made for that. So all of those bony prominences, good to go. These places, be aware of those if you see these, because they should be red flags. The other red flag should be if you have those bruising, even on the shins or on the arms, in a non-ambulatory child. Help me explain how a child that just lays there is going to bruise their shins or their arms. Right? So bruising in a non-ambulatory child should make your red flag go off. Any kind of pattern, so if you can tell what injured the child, that should make your red flag go off. Any kind of pattern at all. And then burns, and we'll talk about how do you distinguish what is an abuse burn, likely, versus what is an accidental burn. Because accidental burns, bruises, and injuries happen all the time. So how do you as a provider be able to separate what is what? On that note, so there are a few, very few, but pediatricians who, after a 3-year residency, will go do a 3-year fellowship in child abuse to help delineate that out. So if you ever have questions, the military has several of them, and there's one at BMC then to say, I don't know about this, can you help me kind of delineate this? So you will not be on your own like that. Fractures is the start of this one as well. So you'll need to know which ones are likely to be accidents versus not. So again, if you can't walk, if you cannot propel yourself, very unlikely that you should have any type of fracture unless something abnormal is going on. So unexplained fractures in non-ambulatory kids. What did we talk about at birth that was the exception to that? Clavicle, yep. So a clavicle fracture at birth would be outside of that. Otherwise, fractures in non-ambulatory kids are not normal. Certainly, multiple fractures are not normal. So if you had that one off, that is really, really wild. I wouldn't expect you to have multiple concurrent fractures. So things that are highly, highly suspicious for abuse then. So any of these are going to take a lot of force. So particularly a posterior rib, so really any rib, but really we're going for posterior ribs. The mechanism of that is usually squeezing really hard. Any kind of metatarsial fracture, scapular fracture, vertebral fracture, it's either from a lot of force, so think about how much force it's going to take to fracture a scapula, or quick jerking motions that are going to pull up the edge of the bone. So those are the things to be aware of. So those, if you see any type of those fractures or any kind of that on a read, on a radiology read, that should make your red flag go up. Certainly blunt force trauma and any kind of abdominal trauma, something to think about. These can be misleading. The belly, and they have those big toed bellies, so the belly can hold a lot of blood before you notice that something's going on and they have an acute abdomen. And then head injuries. So relative to their size, babies' heads are gigantic. Their necks are very, very small. So their heads are at high risk of injury, especially from those shearing forces. So you see this a lot. These are the two most common things that you will see with that. Subdural hemorrhage or subdural hematomas, and then retinal hemorrhages. Their eyes are developing real time for all of that vision. So those vessels are very, very, can be very friable and bleed easily. So retinal hemorrhages, subdural hemorrhages often will come from some sort of shearing or shaking force. So this, what this is trying to show you is that this child came in with a head injury, so 3 months old, so you should know they are not walking, they're not ambulatory. Really not a good mechanism for them coming in with a head injury. Come in with a head injury, and then what they do is they get something called a skeletal survey. So you can do it 2 ways. The first one is called a babygram. Super cute little x-ray, and it just takes a picture of the whole baby. One x-ray picture. So the babygram showed, oh, there's concerns for some fractures. So then a specific skeletal survey is ordered where they take x-rays of every bone. They take multiple angles so you can see all the different angles of this entire baby. When they did that, they then did a bone scan. What the bone scan shows is all kinds of multiple different fractures at different sites, looking at some of those posterior rib fractures and multiple different healing. When they followed this up a couple weeks later with a secondary chest x-ray, they showed those posterior rib fractures healing, and then again, those various stages. That would be a kind of how you would walk down that. You start seeing one thing and you start pulling on that string, and there's typically other things underneath that. Now, we just said, hey, how do you tease this out? You can't just say every bruise is abuse. I mean, I guess you could, but you very quickly realize you're wrong. So what is your differential going to look like then? So we had talked way back in the beginning about dermal melanocytosis, when those melanocytes got caught in the dermal layer. And you saw this early on in that newborn exam. So those slate gray macules or the slate gray nevi or dermal melanocytosis, any of those old names, Mongolian spots, that they come out with at birth that you see on their lower back and buttocks typically. And that would be one of those reasons that you are start documenting those early, because that can save you a whole lot of time, effort, energy, heartache later on down the road if those get confused. Again, we talked about cultural things. Do they do cupping, pointing, anything like that that's going to make it more likely that they are coming in with what looks like a bruise. Certainly, if you are worried about any kind of bleeding here, this would typically, the presentation should follow. So if they were completely fine when they're just laying there, and once they begin to be ambulatory, then you start seeing some of those bleeding into the joints, abnormal amounts of bruising. That's when you would start thinking, hey, something is going on. So typically that presentation will start at about, when do they become ambulatory? When do they expect them to crawl? How many months? About 9 months, yeah. So some sort of ambulation around 9 months. So if that's the presentation, or you see something on a test, they're totally fine. And then at 9 months, all of this stuff starts happening, and they have deep bruising and bleeding in the joints, that's when you should start thinking, ooh, you have some sort of blood or bleeding discouragement. Potentially other platelet disorders too. And then if you've ever heard of just a quick word on osteogenesis imperfecta, so it's brittle bones, so they do not have all of the makeup to make specific the correct structure of bones, so they break very, very easily. When I say very, very easily, you might come out after being born with multiple fractures. So it wasn't just the clavicle fracture, you're born with a femur fracture, humerus fracture, rib fracture, and your clavicle fracture. You fracture your rib from having a cold where you were coughing too much. So that type of, that's the amount of force that it takes for true osteogenesis imperfecta. What is the child going to present like then? So certainly they could be very wary of the adult with them. So again, if they are coming to you as the stranger way more easily than they are going to their caregiver, something to think about there. They are afraid to go home. So sometimes I've had teachers call me and say, this child just does not want to go home. You see this in your clinic as well. Let's see, inappropriate clothes. So you see this sometimes with teenagers, right? We live in San Antonio in the summer. The teenagers come in with like hoodies and clothes and boots and all kinds of stuff. One of the things to ask, just like we would do in clinic court, hey, can I get your hoodie off? Can I get some of this off? Some of the times you will see that they are hiding abuse. Some of the times you will see that they are hiding self-mutilation in the form of cutting, as one example that you might see. Moving uncomfortably. If you've been around a child at all, you should see them hopping, jumping around. They look like Tigger from Winnie the Pooh just all the time. If you see a child very gingerly getting off an exam table like it hurts, that should make your red flag go up. That's not normal that they're moving very uncomfortably. And then again, if the parent is very controlling, if they're doing that and yelling at a child or controlling in an exam room with you present, Lord only knows what they're doing when you're not present. So different patterns that you're seeing of bruising. So when you're thinking about bruising, again, not everything is child abuse. So your number one differential is this is completely accidental. Just absolute accident. That is your number one cause all the time. Then you're down your list. Yes, we have some other things. So those slate grade Levi dermal melanocytosis, absolutely. Some of your bleeding disorders will move up the list. You've got some of those cultural and infectious things going on. And then way down in there, that's when you're thinking also is abuse on my differential. So I will tell most people that I'm precepting, I give it a 3 strikes, you're out. So if you think to yourself, that's a weird bruise, I give you a weird story, and whatever else you think about it again, it pops into your mind, something else, you've had 3 things that make you think, oh, something's not right, I need to investigate this further. This is what I was talking about with the protected places versus not. So the ones at the top picture over here on the left, that's where you expect little toddlers to bruise everything. The big forehead, shins, back of the arms don't show it, but right any over those bony prominences, and then falling kind of on the upper part of their back of their rear, so not on their buttocks themselves. The red would be what you would consider absolutely not normal. So the torso, fatty portions of your legs, ears, eye sockets, buttocks, those would be considered absolutely not normal. I prefer that picture on the left to the right. If you like the one on the right, great, but the colors and pictures, it's really good for communication. So can we use this? So the short answer is yes and no. And so no, this cannot be used legally to say, I know that at this date and time, this bruise occurred and this is what happened to this bruise. However, you've learned physiology. You've taken biochemistry. I hopefully have beat into your head how much I love bilirubin. And so understanding the physiology of I have a red blood cell, it is breaking down to heme, to biliverdin, to bilirubin, and what those different colors of that process and how long that is going to take should help you understand the different stages and give you approximations of when things are occurring. So if you are seeing things that are purple and are red and are brown and are green and are yellow, you are very easily able to tell there are different stages. This has happened at different times because the physiologic breakdown of the red blood cell is occurring at different stages. So it can give you approximations. So as a provider, if you are asked for a specific opinion, you can say, yes, there is bruising. It's the breakdown of red blood cells. It's occurring at different stages and different times. So that very much you can say. You cannot say, 6 weeks ago, there's this bruise from this instrument on this day. Right? You can't say that. So that's how you can both use it and not use it. This would be an example of various stages. So what do you think about where this is on the child? Is it in one of those non-concerning places or a little bit more concerning places for a toddler? So a little bit more concerning. You're on the buttocks and those upper thighs. What colors of bruising do you see? See some purple, see some brown. So already, is this multiple stages or does this look like this was a one-time thing? Okay, so already, you as providers are able to say this is an inappropriate place for bruising, and this bruising is showing multiple stages of healing. So something more concerning for abuse at this stage. These would be those unusual locations. So again, typically ears are not where you see bruising. Face for children is not where you see bruising. But typically ears, people will think that they will not bruise. So the side of the face and ears is where they will twist, they will pull, they will yank, or they will grab the whole ear. So that can be something that you should be looking for. Quick visual exam. If you have a patient who is covering their ears constantly, that would be an indication to take a look. Because that would be one of those unusual locations that you don't expect to see. And a quick mnemonic device, I kind of like this one, of where should you see bruising, not see bruising. So if you see anything in the torso, it's a protected spot. Anything in the genitals for any aged child, that should raise your red flag. That's never okay. Ears we've already talked about, and neck is a pretty protected spot. A frenulum, so what the frenulum underneath the tongue, if that is busted, most of the time that is from a family that is jamming a bottle into a baby's mouth, and it will break the frenulum, so that would be something to look for. What else? Something to consider, so subconjunctival hemorrhages. So that can be from that increase in pressure in Valsalva. So that can be normal if it is a baby that has come out after birth, who's just been squeezed to death, squeezed to life. Or if you have a child who has a chronic cough, or they have a RSV, let's say, and they've just been coughing. So that Valsalva can cause some of those conjunctival hemorrhages. And then again, under 4 months, or that non-ambulatory child really should have no bruising whatsoever, because then those cute little cockroaches that are just laying there. I say cockroach lovingly. They just mean that they lay on their back and can't do anything. Okay, before we get into patterns, let's take a break here and come back at 11:07. This topic isn't great. So, back to what we were talking about, bruising, patterns. Patterns never normal. So that should just be one of those things. See a pattern of any type of injury, not normal. So does it really matter what it is? Not particularly. Don't spend your time learning these things. Spend your time thinking patterns are not normal. So if I see something and I could tell what caused this, right? I don't need to spend my time being like, well, was that a hairbrush or a spoon? If you're thinking to yourself, that was a hairbrush or a spoon, that's a pattern. So that you can start seeing that probably shouldn't be there. Again, very clear, if you're seeing something that's a cord leaving a mark or something across the face, where it's very clear what that is, something to be aware of. What do you think happened to the girl on the left? A slap, yep. And then what do you think about the bruising on the right? What do you have? What about where it is? Inappropriate or appropriate? Inappropriate, what about the colors? Different colors, so different stages. And then this was a child who was beat with a board over and over. So not a normal thing that you would see for this. This is a instance where there was a fight going on with the family. The girl was wearing a necklace and she was pulled up from her neck with the necklace. And so that left that pattern. So again, you don't need to know, was it a silver or gold necklace? None of those things. It's a pattern. So it is considered abnormal. Any kind of cord. So a cord, usually it's from some sort of being almost whipped. So something to look at and think, is that what's going on here? A lot of times the cord will be in half, so it's a double cord. And you see the different angles of how it's hitting the child at different trajectories. So, not normal. Not normal, same thing. You're seeing different stages along different places. You don't expect that in the upper thigh region here. This is an example. This was a baby who wouldn't stop crying. And so the child had a rope put around their neck and strangled, and also was tied to the crib so that they could not move around their hand, and so had distal edema, distal swelling. So again, not ambulatory, not normal pattern for this age child. What about this though? What about bites? Right? What kind of bite marks do dogs leave? It's hair. Yep. What kind of bites do cats leave? Puncture. What kind of bites do humans leave? Yeah, very circular. You look canine to canine oftentimes. So what's that one up on the top right? Cat. What's the bottom one? Human bite. What's the far left? Or left. That's a dog, yeah. So not all things where you're like, that's abuse. It is. Now certainly, could you have neglect in the setting of this, where something was going on, not being watched, and you got attacked by a dog, and then an unexplained delay in care, right? You could see how these stories end up where you have multiple things layered on top of each other. Burns. So burns. I was just talking with someone over the break. Kids love to burn themselves. If it is hot, they want to touch it. If they shouldn't touch it, they want to touch it more. And all things ramen noodles, if a child can burn themselves, it will be with ramen noodles, I swear to you. I do not know why they love to burn themselves with that. That is what they love to do. So again, any kind of pattern. If you are thinking, wow, that burn looks like a fill in the blank, not normal. And then we're going to specifically talk about immersion burns. So if you have a burn that is accidental, it is usually a splash burn. Something fell on you, spilled on you, you dropped it on something, and there is a splash pattern. It is not usually circumferential. It does not usually look like somebody dipped your hand or foot or buttocks in chocolate. And in response to usually being dipped or set in something hot, your response is it usually to extend or to flex? Flex, yeah. So the child is going to try to flex. Even if they are being held under, they're going to try to flex. And so typically immersion type burns will spare your flexural creases. So any place where you have a flexural crease at all, that is going to try to be spared. Will not have that splash pattern and will typically be pretty circumferential. That would be your example of immersions. We'll take a look at some of those. So this would be examples of different types of immersion. So on that first one in A, what they're trying to show you is those flexural creases. Even on the torso, even in the genital region, it still looks like those flexural creases were preserved somewhat. The foot, it's circumferential of the foot and of the hand, and then of the buttocks, again, looks like they were just set right down in that. So these would all be examples of, this is not a normal burn pattern. It's again, circumferential, flexural creases, and those things, and not normal distribution. I would expect a hand at the top of the hand, I wouldn't expect a whole hand dipped in. This is an example, even online knows that kids love to bring themselves to ramen noodles. So this would be one of those things. This does happen. So number one, that's absolutely going to be normal. A kid will find a cord, anything hot, and they will pull. So number one, you're going to see that splash pattern, completely normal. The middle one, we don't love, as pediatricians, the little walkers that children can use, because it takes somebody who is not developmentally at that stage and gives them that ambulation ability. So now you have this person who shouldn't be ambulatory, who has walkered themselves over here, who now has the ability to pull this down. Now they are in a situation where the hot liquid potentially will stay on them and they can't get out of that situation. So pediatricians, I don't love walkers, I don't love juice, I don't want to do that. And then the last one, really always considered abuse if you were dipping or immersing your child, and then again showing that there's that flexural response. Immersion patterns, same things, you're seeing them be immersed, inappropriate spots for inappropriate age, so those flexural creases are maintained, again, circumferential, not normal. Another immersion, same thing, whole hand dipped, circumferential. This one would be that accidental. It looks like it's not patterned. It looks like it has a splash. The whole foot is not involved. Blistering just in some areas. So should be able to see a difference between I am fully immersed, a whole hand, circumferential, versus I have a splash pattern, just some areas. It's that accidental. What about this? Does that look accidental? Do you see any kind of patterns? Yeah, so you see a pattern, think to yourself, already because I'm seeing a pattern, this is probably not accidental. So in this case, this child was crying, wouldn't stop crying, and so was set down on a hot radiator grill. So that's what you're seeing. So not normal at all. What about this? Does it look like a pattern? Does this look like a pattern or not a pattern? Pattern. When you have a child who just touches something hot, do they usually just like leave their hand on it? They pull away really quickly? Yeah. So not that it matters what the pattern was, but this was a curling iron that was touched to a child and just left there. So again, that would be if you hit something hot and you move away really quickly versus I left something hot there for it to leave a mark. So this would be a pattern of curling iron. What about when they're small circumferential all over? Cigarettes. Yes. So you can see these patterns. So when doing a full physical exam is really important for pediatrics because these are the types of things that sometimes you find. I had a friend who had a child come in coding and they were unable to revive the child. And the child looked really, something didn't look right. And so after the code, all of their hands were kind of brown. So the family had put makeup on all of the different bruising and all of the different cigarette marks before they brought the coded child into. So all kinds of things will happen. So a good physical exam is very important to make sure you can find these things that are going on. Your differential is going to be the same. The number one cause of burns, ramen noodles, right? Totally accident. So accidental burns, you see those all the time. Kids find the hot things, they touch the hot things, complete accident. Other things that you see, infection looks very similar. So impetigo and Stoldenstian syndrome can look very similar to a burn in a child. and all kinds of different drug reactions, and again, those cultural considerations, still a very common thing. So burns do not always, in any way, shape, or form, always mean abuse. It's something to think about in the back of your mind. Fractures, we talked about a little bit of those fractures. So things that are suggestive of this. Well, spiral fracture, why is a spiral fracture? Consider that. Yeah, because you're twisting, so there's a lot of twisting going on. I will say the most common thing that I have seen, accidental spiral fractures, is if a parent goes on a slide with the child and the child's legs get tucked under and they end up with a spiral fracture from that motion where the parent just kind of takes them up. So be careful if you're sliding with your children. Don't do that. Or we talked about the buccal handle fracture. So this is not a buccal fracture where the bone crushes in on itself. This is literally where the corner of the bone is ripped off from that ripping motion. Okay, so buccal handle fracture, different than a buccal fracture. Those are those ones I need you to know. Not accidental fractures, unless you can give me the exact mechanism and a good story. A lot of these things, again, scapular fractures take a ton of force. Posterior rib fractures, not okay. Sternal fractures, think about the force that that's going to cause. Unless you have this whole family was in a car accident and they were appropriately seatbelted in their sternal fractures, not normal. And then skull fractures that are not linear. So one of the things you will see is one day kids become mobile and they just take off. And so one of the most common mechanisms is you will see a kid that is strapped into the seat at Trader Joe's or Central Market or wherever, and suddenly they decide that they are mobile, they're able to get out of the seat and fall out of the grocery cart. So you see these linear skull fractures quite frequently. When they're not linear, when you're looking at there is some sort of blunt trauma to them, that's when you start getting concerned. And again, those skeletal surveys are when you have all those different pictures that you're taking of this entire baby. Yes, sir?
Theoretical situation of like the car accident, where it was very obvious that the child was being on the train and they were running its way back. Like at what point does that cross the line between like neglect, inability, like ignorance, naivete, like whatever?
Yeah, it's a good question. How do you determine in those situations what's neglect, what's ignorance? How do you know? Situation by situation. So that's why your provider brain and using all of your pieces. Have they gone to well visits? Is this a responsible family? Do they have? Are they like, oh my god, I can't believe this happened. I didn't check. Or are they like, yeah, no big deal. We don't buckle. Right? You're having to put this entire piece together to say, is this truly neglect? Is this truly abuse? Do I need to make a report? Right? Great question. When we both figure out the answer to that, we can figure that out together. Again, your differential, kids break bones all the time. They break bones much easier than adults do even. So adults are going to get sprains, tears, strains a whole lot more often. Kids are going to break things, dime a dozen. So accidents are going to be your top differential. With those other things to think about. You have your osteogenesis imperfecta, you have some of the trauma, you have rickets, all of those less likely. An example of that spiral fracture has a twisting motion, which you're seeing. So an example of that bucket handle fracture, and why you're seeing that, the bucket handle that's coming off just like the edge of the bone from that quick jerky motion. You see again a scapular fracture, think to yourself, how did that happen? What amount of force is coming at this child that made that fracture possible? Much like your bruising, your fracture stages of healing are going to give you that general indication, right? I cannot say this injury happened at this date and this is exactly what my mechanism was, but knowing what you know about ortho and bone healing and at what days and weeks you have different types of periosteal and callus formation, when you see those different stages, you should be able to say there's multiple fractures and multiple stages of healing. Right? So that is something that you absolutely can say. So be an example that you're seeing, I'm seeing those posterior rib fractures, and now I'm seeing them start to callus, while at the same time I'm seeing acute breaks, acute callus formation at different parts of the bone. Again, from this baby, you are able to say there's multiple fractures and multiple stages of healing that are in abnormal places, posterior ribs, some of these long bones, and a non-ambulatory child. So that is absolutely within your provider realm to be able to give that assessment. Abusive head trauma. So again, this one's going to be the most likely reason for that mortality. It's going to again be the physical abuse piece, often in a clinical vignette, and in real life you'll see this in a paternal or a male figure role of the primary caregiver situation. And often in a non-ambulatory child that cannot move and is in that period of purple crying, or slightly a little, or maybe a little bit older. So what was that period when you see colic? 6 weeks as your peak of that, but really 5 months and under, where you have a completely dependent child who is really only crying to get your attention. And so that mechanism of that shaken baby syndrome, where you have those shearing forces and the things that it's going to cause will break those vessels in the retina and in the subdural space, so you end up with subdural hematomas or hemorrhages, retinal hemorrhages, and then significant amount of swelling. So this is when we're very glad that the sutures are often still open, because that's an area to decompress. But please be aware of those particular findings with shaken baby. An example of that subdural hematoma that you might see on CT. So if you are thinking this is going on, this would be an indication to get head imaging. I have not yet said that at all, besides ultrasound for children. This would be one example. If you think there's abusive head trauma and the sutures are open or even closed, a subdural, if you're thinking that, you will need advanced imaging. Who's super awesome with a fundoscope exam in clin lab? None of us, right? I will say that very clearly. I'm not awesome either to particularly look at all the retinal vessels. But what I can see with retinal vessels are the lining of them and see if they are following a tract and if they are bleeding outside of those vessels. So if that is what you are looking at and you see something that is not normal, right? You don't have to be awesome with a fundoscope to say that's not normal. It looks like there's bleeding there. I need to get an ophthalmologist who can take a further look. That's all you need to do in this instance. So this would be an example of some of those retinal hemorrhages that you also see from shaking. Again, normal, not normal. This does not look normal. You don't need to be an expert to say there looks like there's some bleeding in that retinal space. Certainly there can be these accidental head traumas again, baby that falls, that suddenly becomes ambulatory, and this was the first day that we weren't supervising them. That happens all the time. I had a resident friend, we were in pediatric residency together, and that's the exact same thing that happened to their son. And so it happens. So those small linear fractures, often accidental, so larger ones, not accidental. Things that might make it worse. We talked about what do you get when you're first born? What are those eyes and thighs? Hep B and vitamin K, right? So if you didn't get that, so you had a home birth, parents declined it, you didn't get that vitamin K, and something happened, now you have a higher risk of having that vitamin K deficient baby. So things to think about. Quick word on sexual abuse. Like I said, we're not going to spend a lot of time here, but epidemiologically, a lot of these are going to be reported to be girls. What you will probably see as more and more data comes out is that many of young boys, it is either not recognized or just not reported. So the numbers probably are a little different and higher than we see, but right now the studies show there's about 80% of these are girls. A lot of these are because the children are groomed over time. They are not reported for years, months, way later, if ever. One way that they can present, recurrent UTIs in a pre-pubertal child. So particularly for girls, that is very common, especially while you're learning to potty train. So your highest differentials, number one, I have constipation. So chronic constipation is like 99 times out of 100 what this is. Number two, it's hygiene. So is a little girl or a little boy learning to potty train and learning how to do this by themselves. Number three is GU abnormalities. Is their anatomy normal? So potentially not. After that, it's abuse. So recurrent UTIs obviously does not just mean this is abuse, but it's something to think about, should be on your differential. And really any kind of sexually transmitted infections in a pre-pubertal child should just absolutely raise your flag. If you have gonorrhea in a 7-year-old, that's not normal. I hope that I don't have to tell you some of those things. Things that you could consider might make a little bit more of a determination is if you had genital warts, because that is something that they induce that there's some self-inoculation there. So something to think about. But certainly syphilis, gonorrhea, chlamydia, any of those type of things, not normal ever for a pre-pubertal child. What might this look like? This might look like a child who knows things way too early. They know way too much, way too early. And that's typically often how they will present. They will start telling or they will start doing something to another child, and that other child is like, whoa, 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 what's going on? And often that's how it gets reported. So advanced sexual knowledge. If your 4 or 5, 6-year-old knows things that there's no way that they should be knowing, that should be a red flag for you. Sudden changes. This child was doing awesome in the 3rd, 4th, 5th, whatever grade. They're doing so good. Now they hate school. Their grades fall off. Something's happened. What is going on? Divorce, bullying, yeah. Is abuse on there? Is there sexual abuse going on? Something to think about. New night terrors, nightmares. I want to run away. I don't want to go here anymore. I don't want to go to soccer. I don't want to go to youth group. Whatever it is, those can be presenting signs and symptoms. And then sometimes, obviously, or not so much obviously, but a suicide attempt or severe and sudden depression, anxiety can be some of this as well. Your exam is often normal, especially with that delayed reporting. However, those traumatic injuries or traumatic instances, you do have 72 hours to get the specialized exam. So what is that specialized exam? So different hospitals will have a sexual assault nurse examiner or a SANE nurse. So it would be one of those things to know as a provider is where is my nearest SANE nurse? We talked about for PEDS, I need to know where my NICU is. That's one thing I need to know. Now I need to know where my SANE nurse, my sexual assault nurse examiner, but now I need to know where my PSANE nurse is, pediatric, because it's specific. So I believe that SAMC has a SANE nurse, University has a SANE nurse, and all of them for children go down to CHOSA for the PSANE exams. So the city hasn't even figured that out. So that's important for you to know as a provider is where is my SANE and PSANE examination is going to happen. So that is not on you to then do a sexual assault examination. It is on you as the provider to get them to a SANE or PSANE. And within 72 hours of that disclosure. Emotional abuse can come in all of shapes and sizes. I think we already talked about this. A lot of times if they are seeing abuse, that can be one of those risk factors. It can be aggressive, angry, failure to thrive, and look at various different signs. What might that look like in the child? So these children might have some delays, difficulty making friends, have habitual disorders that they are doing over and over to try to kind of self-soothe or self-cope. So it's a good question over the break. What in the world do we do with this? So how do we report? So number 1, you are not the investigator. Number 2, you are a mandated reporter. So you must report. Well, who do I report to? And how do I know if I should or shouldn't report? Well, the definition and the way that you will be determined as a provider of who is going to, if that report is going to get you in trouble at all, the short answer is no. If you are acting in good faith on behalf of your patient because of something that you suspect that any other reasonable provider would think, then that is absolutely within not only your right as a provider, but what you are mandated to report. So you do not have to have certainty that this is what's going on. You have to have a reasonable suspicion and make a report in good faith. So, who is this report, this magical report, who is this made to? Well, it's going to be state by state, and so there will be a Child Protective Services, a Child and Family Services, a Child and Youth Protective Service. Every state has a slightly different acronym with different reporting requirements. some it's online, some it is face-to-face, some you will call, some you will do both. So each state will have a different reporting requirement. Inside the military, you have the family advocacy program that specifically works with the local community and the local state. And they act as a family and CYFD inside of the military. So that gives you some more options to be able to offer services, have other reporting routes. And if you are active duty or if you are on Title 10 and you are on current orders, you have the command structure that can be very helpful. This is one of the times where I've been the most thankful for active duty, because this is one area that commanders, in my experience, have little to no tolerance for. So, super helpful. Your failure to report is going to get you into more trouble. So if you know and you documented stuff, you wrote in your note, I'm concerned for child abuse, and you didn't do anything with that, in Texas, that's a misdemeanor. So you are going to have more likely chance that you are going to get in trouble for not reporting. So, but state by state, knowing who your families that can be helpful. This is the website. If you ever need to know, well, this is the state I'm going to, this is where I'm going to be practicing. This is what I'm going to do. What do I need to do to report in this particular state? That is one place you can go for details. So hopefully you never see any of this in your career. Unfortunately, we probably all will. So what do you need to do? Number one is document, document, document. Put things in quotes. Put who was in the room. Put who your chaperone was. Put what your exam was. Put what wasn't there. So if something wasn't there, I didn't see any hair loss. I didn't see anything with the nails. I didn't see, put what you didn't see in addition to what you did see. And your PSAME exams needs to be within those 72 hours. If you are in an ER setting, or even if you're in an outpatient setting and you're concerned for imminent safety, admission is always an option. So you can always say, I am going to admit for observation for safety and welfare of the child. Absolutely, absolutely within your rights as a provider to do that. One other word, if you think to yourself, if you don't hit that 3 structure out or however you come up with for your own thing, if you think to yourself, could this be abuse? You better write all kinds of stuff for why you're not going to do something, because that documentation, should something happen, is going to be just as important. And if you like to study with that, it will eventually get to report what you need to report, don't report what you don't need to report. We'll go over a little bit of some learning checks, but then I want to tell you guys just a couple of quick stories. So, what are some of those red flags for abuse? Patterns, unusual stories that don't match. Avoiding that, not wanting to go home, avoiding. Self-harm in teenagers, absolutely. So a lot of red flags. So please be able to pick those out. Any kind of questions? How would you want to interview this child? Alone, if possible. With a chaperone. What kind of questions? Yes, no, open-ended questions. Yep. What are some of those long-term complications of abuse? Why do we not want this? Not just because we don't want abuse today. Violence, mental health disorders, sleep disorders, more likely to abuse in the future. And then some of those common characteristics, that's probably a bad question because it's just really broad. So what I need you guys to take away from here, from this lecture, for testing purposes, what are your red flags? What are those unusual places? What are those things that you would not expect? How do you pick out what's normal, what's not normal? So kind of some of those general things. So what I just wanted to take a few minutes at the end here, because some of the time